For the same, I would like to invite our chairpersons. May we have Dr. Sudha from Fortis Hospital, Bangalore, Dr. Nasiruddin G from Bangalore, Dr. Aditya Choti, Bangalore, and Dr. Toda Radhakrishna, Bangalore. May we have our chairpersons here on the stage, please. So let us begin our session. I would like to invite Dr. Thianeshwaran, medical oncologist, Fortis Hospital, Bangalore, to talk about cancer treatment by systemic therapy. Hand over the mic.
Thank you. Thank you, Dr. Dinya. So today I'm going to talk about chemotherapy. So how we are going to treat the cancer part. So there are multiple methods are available. One of the method is chemotherapy. So before going to the chemotherapy part, so definition of cancer. So cancer is a large group of disease that can start in almost any organ or tissue in the body. When abnormal cells grow uncontrollably, go beyond their unusual boundaries to invade adjoining parts of the body and spread to the other organs. Later it is called metastasis. So what are the treatment modalities? So chemotherapy, hormonal therapy, and targeted therapies, immunotherapy, radiotherapy, and surgery. So I am going to talk about chemotherapy. So what is chemotherapy? So chemotherapy, there are two entities. One is curative intent, another is palliative intent. So curative intent, we have neoadjuvant chemotherapy and adjuvant chemotherapy. So what is neoadjuvant chemotherapy? So neoadjuvant chemotherapy given before the definitive therapy, means surgery, before surgery. So adjuvant chemotherapy, after the surgery, we used to give adjuvant chemotherapy. Example, breast cancer. And neoadjuvant also best is breast cancer and stomach carcinoma, rectal carcinoma, and lung carcinoma. So palliative chemotherapy. So palliative chemotherapy usually we prefer in stage 4 cancer. Our patient is refused for aggressive line of treatment, we'll give palliative chemotherapy. So palliative chemotherapy may be a mild form of chemotherapy, or it may be a weekly infusion or a tablet form of chemotherapy. So why combination? So chemotherapy can be delivered in single agent or combination regimen. So what is the advantage of combination regimen? So we can get maximum benefit and preventing the drug resistance and to kill the resting and dividing tumor cells. So it can be given in short course also. So what are the routes of administration? So we have we can administer as IV, subcutaneous route, oral route, or intra-arterial, particularly in hepatocellular carcinoma, intraperitoneal chemotherapy, particularly in ovarian carcinoma with peritoneal metastasis, and intrathecal chemotherapy, particularly in brain metastasis patient and leukemia patients. So what are the factors affecting the chemotherapy? First thing is tumor factor. So tumor factor means there are multiple resistance mechanisms available. So it can resist against any kind of drugs. Next important thing is patient factor. 4 functional factors: impaired organ function, particularly renal failure and liver failure. In that case, we cannot give adequate chemotherapy dose. So response to the chemotherapy also will go down. And comorbid conditions, particularly diabetes mellitus and cardiac failure and systemic hypertension. See, the diabetes is very, very important factor because chemotherapy drugs, few drugs we have to mix in dextrosolution only. If patient sugar is not under control, immediately post chemotherapy they will develop hyperglycemia. So before going to chemotherapy, so chemotherapy broadly classified into cell cycle specific, non-cell cycle specific. So what is cell cycle? So cell cycle having a interphase and mitotic phase. So interphase and G1 phase, S phase, and G2 phase. So how we will target? So it is cell cycle specific. Cell cycle specific means chemotherapy particularly act on the one specific phase. Example, S phase, antimetabolites, particularly cladribine, cytarabine, 5-FU, hydroxyurea, methotrexate, pentostatin, and thiopurines. And G2 phase, etoposide, pinoposide, irinotecan, and topotecan. So mitosis phase, taxanes, and vinca alkaloids. So G1 phase, dactinomycin. So what are the side effects of chemotherapy? So common side effect is GI side effects, mucositis, nausea, vomiting, diarrhea, and constipation, and myelosuppression, cardiotoxicity, neurotoxicity, nephrotoxicity, and uncontrolled diabetes, hair loss, fatigue, and skin change. These are common side effects. A lot of side effects are there, but this is the most common presentation. So nausea, vomiting. So nausea, vomiting is classified into 4: acute, delayed, anticipatory, and breakthrough. So acute means within 24 hours of chemotherapy delivery. Delayed means after 24 hours of chemotherapy delivery, patient will get nausea. So anticipatory means we can expect this patient will develop nausea because there is any history of previous exposure of chemotherapy or radiation to the stomach or any GI disease. So breakthrough vomiting. Breakthrough vomiting means during nausea vomiting treatment itself, patient will develop vomiting. It's called breakthrough vomiting. So chemotherapy drugs classified based on the emetogenicity. High emetogenicity means the above 90% of the patient will develop nausea vomiting. Best example is cisplatin and cyclophosphamide AC regimen. Because atreomycin and cyclophosphamide regimen commonly used for breast cancer in adjuvant and neoadjuvant settings. So moderate emetogenic, 30 to 90% of the patient will develop nausea and vomiting. So carboplatin and cyclophosphamide also less than 1.5 gram. So there are other drugs also there. So low emetogenic, 10 to 30% of the patient will have emesis, and minimal emesis, minimal less than 10%. High emetogenic, we have to cover 3 drugs. One is serotonin inhibitors, and is dexamethasone and aprepitant, so NK1 inhibitors. So all 3 drugs we have to give in the day one means before starting the chemotherapy. Day 3, day 4 also we have to target the target. So from day 2, day 3, day 4, dexamethasone is mandatory. But if you are giving aprepitant in the tablet form, so day 2 and day 3 will be there for emesis. So moderate, again, 2 drugs is enough except carboplatin. If AUC is more, we have to give 3 drug regimen. And again, day 2 and day 3 also dexamethasone required. So what is the mucositis? So oral mucositis, it's a significant problem in patient undergoing chemotherapy, both solid and hematological malignancies. So almost 51% of solid tumors and lymphoma patients will develop mucositis. That oral mucositis itself, 22%. So why this oral mucositis is important? Because it significantly affects the nutritional status, and patient lost the weight more compared to tumor-related weight loss. So how will you grade? So grade 0, no oral mucositis. Grade 1, erythema or only soreness. Grade 2, ulcer able to eat solid food. Grade 3, patient can take only liquid food. And grade 4, ulcer and ulcer GI tract you cannot use. So it's a grade 3 to grade 4 mucositis. So how will you treat? So first, painkiller, we can do NSAIDs. And nutrition support, particularly in grade 3 and grade 4 mucositis, parenteral nutrition is important. So oral decontamination like saltwater mouthwash, betadine mouthwash we can do. Antibiotic if patient having a severe mucositis like grade 3, grade 4 mucositis with neutropenia. So patient, if we are expecting patient is going to develop fever, sepsis, that time definitely we have to start antibiotic as an antifungal also. So next, diarrhea. So based on the grading, grade 1 is less than 4 stools per day, 2, 4 to 6 stools per day, grade 3 more than 7 stools per day. So grade 4 is life-threatening diarrhea, grade 5 is death. So how we will treat diarrhea? So grade 1 and grade 2, we used to start with loperamide, 4 milligram. So maximum we can give 16 milligram per day. So once patient settle, we will not start antibiotic. But if patient is not under control with the loperamide, definitely we have to think about infection, and we have to send routine culture and stool routine, and we have to start antibiotic. Say grade 3 and grade 4, we have to start with the loperamide, but over a period of time, definitely we have to start with the antibiotic. So constipation. So again, it's based on grading. This is a grade 1, occasional or intermittent symptoms. Grade 2, persistent symptoms with regular use of laxatives. Grade 3, obstipation with manual evacuation is indicated. Grade 4, life-threatening consequence. Grade 5 is death. So how we will address the constipation? So we will use bulk-forming laxatives, stool softeners like docusate sodium, and osmotic agents like lactose, sorbitol, glycerin, and stimulant laxatives, bisacodyl. So myelosuppression is an important side effects of chemotherapy. So it's chemotherapy damage the hematopoietic stem cells and progenitor cells in the bone marrow. So it produces anemia, thrombocytopenia, and neutropenia. So my myelosuppression is important factor in discontinuation of chemotherapy. And one more thing is it can delay the chemotherapy delivery. And again, the tumor it may help in tumor resistance also, because if you're delaying more than 1 week, again the tumor growth will be there. So the patient may not respond to the same chemotherapy. So how will it treat? Anemia can be managed by blood transfusion, and growth for neutropenia, growth factors like colony stimulating factors, and erythropoiesis stimulating agents for thrombocytopenia. So hematological toxicity, how we will grade? So neutrophil grade 1, it is less than 1500. Grade 2, 1000 to 1500. Grade 3, 500 to 1000. Grade 4, less than 500. Platelet, less than 75. Grade 2, 50 to 75,000. Grade 3, 25 to 50,000. Grade 4, less than 25,000. So hemoglobin, grade 1, less than 10. Grade 2, 8 to 10. Grade 3, 8, less than 8. And life-threatening, grade 4 is life-threatening consequence. Urgent intervention indicated. Grade 5, death. So lymphocytes, less than 800. Grade 2, it is 500 to 800. Grade 3, 200 to 500. Grade 4, less than 200. So we used to measure neutrophil, platelet, hemoglobin, lymphocytes. CD4 count we will not measure, but unless it's indicated, particularly in HIV patients. Less than grade 1 is less than 500. Grade 2 is 200 to 500. Grade 3 is 500 to 200. Grade 4 is less than 50. So febrile neutropenia, it is a ANC. Few studies will say ANC less than 1,500, few will say less than 1,000, with single temperature more than 38.3 or sustained temperature more than 38 degrees Celsius for more than 1 hour. So overall, one single line, like example anemia or thrombocytopenia or neutropenia, 62% of patient will develop. But 2 cell lines involvement, 33%. But in 3 cell line involvement, 15.5 percentage. So neurotoxicity. So neurotoxicity classified into acute and chronic. So acute toxicity commonly oxaliplatin and taxine. So once you infuse, during infusion or immediately after the infusion, patient will develop a choking sensation or some numbness. So they cannot touch the cold items. So this is acute toxicity of oxaliplatin. So another thing, taxine, after the paclitaxel infusion, patient present with severe joint pain. So chronic toxicity, it is a dose dependent. So it is a cumulative. It is a symmetric distal and stalking cloud distribution. It is predominantly sensory, but sometimes motor also involved. Example, thalidomide for multiple myeloma. So autonomic neuropathy, particularly in cancer-induced neuropathy, is very less, but exception Vinca alkaloids. So how we will prevent? There is no clear-cut guidelines available for prevention, but some studies are saying this we can use or we can try this one. First thing is cryotherapy, compressive therapy, and exercise, and acupuncture, and steroids and NSAIDs. So how will it treat chronic toxicity? So particularly in oxaliplatin related toxicity. So once first cycle itself, patient developed acute neuropathy. Next cycle onwards, we can increase the duration. Usually we will give 2 hours of infusion. Next time we will give 3 to 4 hours of infusion. It will prevent the neurotoxicity. So limiting the cold exposure. Again, so we will advise the patient during chemotherapy, after 2 days of chemotherapy, don't touch any cold items, particularly those who are receiving oxaliplatin. And gabapentin and Pingali and topical capsaicin. So cardiotoxicity. So cardiotoxicity, it is caused by anthracycline antibiotic and trastuzumab. So trastuzumab, if patient undergoing any drug like anthracycline and trastuzumab, baseline itself echo is important, during treatment, every 3 months we used to do echo. If there is any reduction in the EF, either global or specific in the intraventricular septum, so we have to stop the infusion, or symptoms or signs associated with cardiac failure, we have to stop. Reduction in the ejection fraction from baseline to 10 to usually less than 10% reduction, we have to stop the trastuzumab. So when we will restart trastuzumab. So usually once you stop the trastuzumab, you have to check echo every 3 months once. So at least 3 months gap you have to give. So usually trastuzumab induced cardiac failure, it is reversible. So once patient normalized the EF, we can restart the trastuzumab. Once if patient is not normalized, definitely we cannot restart the trastuzumab. So what is the treatment? So dextroxone, it works like a chelator, may reduce the cardiotoxicity, particularly in anthracycline induced cardiotoxicity. So once patient developed established cardiac failure, we can give carvedilol, it's a beta blocker, and enalapril. So hyperglycemia. So hyperglycemia during chemotherapy 10 to 30%. During chemotherapy chance is 10 to 30%. So why hyperglycemia in chemotherapy patients? There are two reasons. One is we used to give pre-medication for all chemotherapy patients. So chemotherapy pre-medication is DEXA. So definitely it will increase the sugar level. Another thing is few chemotherapy drugs itself will increase the sugar level. Best example, elaspridine, particularly in ALL patients. And few chemotherapy drugs we have to mix in dextrose solution. Again, it will increase the sugar level. So long-term hyperglycemia is also observed, especially in patients with the hematological malignancies treated with elaspridinase based regimens and total body irradiation. So management of hyperglycemia start with the insulin and sulfonylurea depending on the types, dose, and delivery of the glucocorticoid formulation. So alopecia. So chemotherapy-induced alopecia, probably one of the most shocking aspects for oncological patients, underestimated by physicians. So the incidence estimated to be 60%, even if the prevalence and severity of hair loss are related to the drug category. So and number of drug administration. So particularly in a taxane group, they reported 80% of incidence of alopecia, 60 to 100% with the topoisomerase inhibitors, with alkylators, and 10 to 50% with antimetabolites. So this kind of alopecia, it is reversible. Usually 3 to 6 months it will take. There is no specific treatment available, and few studies tried vitamin D. So fatigue. So cancer-related fatigue defined as a distressing, persistent, subjective sense of physical, emotional, and cognitive tiredness or exhaustion of related to cancer or cancer treatment that is not proportional to recent activity and that significantly interferes with the usual functioning. So approximately 1/3 will have persistent fatigue for a number of years in post-treatment also. So what are the reasons for fatigue? One is direct effect of chemotherapy on the brain. Next thing is anemia, loss of muscle mass, defective metabolism, systemic inflammatory response, and disturbed sleep and hormonal changes. So what are the treatment options? So control the contributing factors. So particularly if anemia is there, blood transfusion definitely will improve fatigue. And non-pharmacological interventions, exercise, cognitive therapy, yoga therapy. So pharmacological interventions, methylphenidate and dexmethylphenidate and modafinil and low dose of steroids. So what are the skin manifestations? So toxic erythema, hand-foot syndrome, particularly in colon cancer patients, they are receiving 5-FU. Eccrine hidradenitis, photosensitivity reactions, particularly in taxane patients, those who are receiving taxane, pigmentation of skin and nail, oncolysis, subacute cutaneous lupus erythematosus, and scleroderma like changes. So usual treatment, skin moisturizing agents, steroid cream. If symptoms are not subsiding, systemic steroid we can use and postpone the chemotherapy. Or if patient developed grade 3 to grade 4 reaction, we can stop the chemotherapy. If skin infection superadded with infection, we have to start with antibiotic. So it is a hand-foot syndrome. Thank you.
Before we go to our next talk and speaker, I would like to introduce myself and the chairpersons. We need no introduction to all the eminent physicians sitting here on the dais. Starting with Dr. Sudha Menon, a senior consultant in internal medicine in Fortis Hospital, Banargata Road. Ma'am has over more than 30 years of experience in treating complicated cases, and her area of expertise also includes rheumatology and other diagnostic complications spanning from difficult FUOs, fevers, also complicated cases when it comes to surgical complications. Ma'am has been an alumni from Grant Medical College, JJ Hospitals, where she has done her MBBS and MD medicine. We are really happy to have her over here, and welcome, ma'am. Next, we have Dr. Tota Radhakrishna, a senior consultant in internal medicine from Richmond Hospital. Sir has a special interest in preventive medicine, diabetes, and endocrinology. With a vast experience of over 30 years in the field, Sir has completed his MBBS from Bangalore Medical College Research Institute, as well as MD from the same alumni. Also a member of Indian Medical Association, and I welcome you, sir. Next, we have Dr. Aditya Choti, a well-known consultant in internal medicine in Cunningham Road, Fortis, with over experience of 10 years. We have Dr. Aditya, who has completed his MBBS from JGM Medical College, Davangere, and MD Internal Medicine from Vaidehi Institute of Medical Science and Research, Bangalore. He's done his postgraduate diploma in diabetology from the Johns Hopkins University School of Medicine and has various distant educational programs which merit credit to his academic credentials. He was also the chief of internal medicine and diabetology at the private hospital before joining Fortis Hospital. The areas of expertise is diabetology, infectious disease, metabolic disorders, adult immunization. We welcome you, sir. Next, we have Dr. G. Nasiruddin, consultant infectious diseases. Consultant in. I gave you my introduction. I was saving that for the later part. Yeah. So, consultant in internal medicine with over 5 years of experience in Cunningham Road. We have Sir, who's done his fellowship in management of diabetes and its complications from Royal College of Physicians, UK. With specialization in treating infectious diseases, diabetes, and complications, endocrinology complications with thyroid disorders and respiratory disorders. And Sir has been working in Fortis for over past 3 years. Welcome. And I'm Dr. Divya, consultant infectious diseases in Fortis Hospital, Bangalore. I'm going to be the host for your evening. We were gathering a lot of people here before the introduction happens. So we welcome our chairpersons and we go on to the next session. So we have Dr. Nishit, hematologist, Fortis Hospital, who's going to speak on malignant and non-malignant hematology.
Good evening, everybody. Can you hear me? So, good evening, everybody. Thank you, Divya, for the introduction. So, when I got the topic malignant and non-malignant hematology, I felt it is a bit unfair to teach such eminent people from the beginning about malignant and non-malignant hematology. So, after doing all my brainstorming how to make it as interesting as possible, so I took up a few interesting cases where our role came into picture after it was thoroughly evaluated by our esteemed physicians, and how we came as hematologists and then how we guided them in the treatment. So in the malignant aspects, most of the time we get reference other than for transplants, acute leukemia, lymphoma or multiple myeloma. And in non-malignant, it's usually drug-induced thrombocytopenia, thalassemia or aplastic anemia. So we'll take the first case here. There was a 28-year-old female, a resident of Bangalore. She had chief complaints of menorrhagia for a month. There was no history of significant weight loss, night sweats. A thorough gynecologist physician evaluation was done. Clinically, she had low-grade fever without chills, rapid 3D pulse, hypotensive, hypoxic, pale, no palpable lymphadenopathy and organomegaly. Investigations on day one, she was taking, was admitted in outside hospital, showed features of pancytopenia and a deranged PT, APTT, INR. Peripheral blood smear showed again features of pancytopenia with no excessive blast. Malaria and dengue were screened and they were negative. Then patient was immediately given supportive treatment with PRBC, platelet transfusions and FFP, and along with antifibrinolytic for the bleeding and broad spectrum antibiotic. And then around midnight, she was shifted to Fortis Hospital in view of severe hypoxia, metabolic acidosis, and put on ventilator support. So there, our reference was taken in view of persistent bleeding was the picture. So initially, I told that we will do a bone marrow aspiration biopsy, but as you know, as hematologists, the moment we say bone marrow aspiration biopsy, half the patients are like, is this going to be painful? And to the answer, yes, slightly. So after convincing them, we immediately did a bone marrow aspiration biopsy, and pretty late at night itself, and we were after the pathologist to release the report whether it is AML M3, because that is what we were fearing. And God, as God would have it, she was having APML. So AML M3 and fish was about 70%. And then we took over the management. So the point here was the physicians and gynecologists in outside setting with all their knowledge and expertise, it's very difficult for them to upfront think, okay, when no organomegaly is there and nothing is there, and even to tell somebody like you have blood cancer, because the reports which they'll be getting will be a generalized pancytopenia report, and they'll be giving all transfusions, and for a week after not treating their way they called us. So we treated this patient with AML intermediate risk CMC Valor protocol, and we treated with mitoxantrone, ATU and ATRA for 42 days. Patient in day 44, we did a bone marrow aspiration on day, currently the patient is day 44. We did a bone marrow aspiration on day 42 and there was no atypical promyelocyte. So the patient is clinically stable, and now all the attenders are very happy that, you know, they came to Fortis and they were convinced for bone marrow, and they believed what they were, because initially she was in ICU and they were thinking we'll go Lama. And the referring physician was worried because she was getting persistent call, bill is going high, they are not able to see. So again, here the role of doing a immediate bone marrow aspiration biopsy when hematologists get a call, because we generally believe that as a physician, they would do everything else necessary before calling us. So we just add to the treatment. We are not going to start from the basics. And since all the evaluation was done, dengue, malaria, nutritional workup, everything, and still, so there we did, and fibrinogen was tested, and we gave aggressive blood products with cryo, and she is doing well, thankfully. So take-home message was to do urgent bone marrow studies, and aggressive blood products in such cases is life-saving. So if you have any patients where you feel that after repeated treatment yet it is not settling down, my suggestion is always encourage them to do a bone marrow aspiration. They might be reluctant in the beginning, but rest assured, once it's done, they will be very happy that they know the diagnosis, and if there's a treatment possible, it is possible. Thank you. Coming to the case number 2. So this was a 50-year-old lady, a resident of Mysore, on a family trip to Bangalore. They had come to visit Bangalore. Surprising enough that people from Bangalore go to Mysore, but here there was a family trip to Bangalore. But she came with complaints of fever to our outside hospital, and workup of dengue malaria was done. In her investigation, there was bicytopenia with hemoglobin 6, platelets as 27,000, and ANC and LFT mildly deranged. Creat was normal, and dengue NS1 came positive. So as NS1 came positive, there was thing that okay, IgM would not been picked up, or just so they were treating for dengue with hydration, blood transfusions, and antipyretics. Then she developed one episode of generalized tonic-clonic seizure and was shifted to again hospital ICU, intubated, and then hematology reference was taken. So as we got a call with a platelet being as low as 27,000. Our first thing was to do a CT brain to rule out bleed. And thankfully enough, that came out as no bleed. MRI was also normal. We sent for nutritional workup, that was normal. LDH was around 3,000 and peripheral smear showed around 10% of cystocytes. Then we did the plasmic score, that is to start plasma exchange, as we know that to start even in the absence of the diagnosis of TTP, how likely it can be TTP. And we got intermediate, it was around 5. So we immediately started plasma exchange, and currently the patient, although still in ICU, but has been extubated and she's doing well. Other things also, she's recovering. We added pulse therapy of methylprednisolone after the Adams 13 report came as nil. That took a day or two. And anti-Adams 13 were high. Now we have repeated it after a week, and again it is showing that Adams 13 activity is increasing from 0. So currently on day +7 of plasma exchange, and clinically LDH levels are coming down. So in this, the takeaway was that already we had a diagnosis of dengue to work with, and since we went through the reports, we felt that the peripheral smear done outside would not have been able to report cystocytes. So we specifically asked for this and then thought towards TTP, because sometimes if you don't start plasma exchange in the beginning, as you know, it's you can lose the patient. It's very critical to start plasma exchange in the beginning itself. Then coming to case number 3, there was a 70-year-old female resident of Tamil Nadu, had recently been discharged post extraoperative laparotomy for perforated duodenal ulcer and peritonitis. On day 4 post discharge, she came with history of chills, right side pleuritic chest pain. The pain was dealt with 5 to 10 severity, aggravated on deep inspiration. Physical examination, she was obese, pulse was around 86, BP was normal, SpO2 was 100 in room air, and rest systemic examination was within normal. So when we then sent for the investigation, hemoglobin was slightly on the lower side, 10.1, WBC was 16,000, and platelets were about 1,70,000. HRCT showed a right side pneumonia, and patient was started on broad spectrum antibiotics. On day +2, this is on day +2 post admission in the hospital, patient complained of pain in the left knee and worsening of hypoxia. Physical examination revealed arrhythmia around the lateral aspect of the knee, complained that it was due to excessive compression of DVT stocking, hence stocking was loosened, and a Doppler was done which showed features of DVT. And on day +7 on treatment, when we started with heparin infusion, because hemodynamically the patient was worsening, so instead of giving Clexane, they had started heparin infusion. So the hemoglobin came to 8.5, platelets came to 89,000, and on admission it was 17,000. Doing the 4T score, it was a high probability of hit. Heparin was stopped and switched to direct acting anticoagulants. Test was sent for heparin for antibody immunoassay. Serotonin assay came 100% positive, and the hit diagnosis was confirmed. So in ICU setting, the most common, I would say, the reference we get usually is for drug-induced thrombocytopenia. Whether it is sepsis or some drug, or thrombocytopenia is the most common reference which we get. And we have to look in whether heparin was going on or not, and based on that we have to take a call. And as we stopped heparin and the platelets started to improve, this is just the pathogenesis of thing that it activates platelet factor 4, which further allows it to bind with heparin and causes endothelial injury. So these are the 3 cases which I thought I will discuss, where the physicians had done all the work and they just took our reference because they felt somewhere that we have to save the patient. See, I've always felt with ma'am, she also, we have had lengthy discussions about her HLA patients, and ma'am has always been asking, and she's always on top of all her suggestions, like, no, if you feel like you should go ahead. Because since you all do the great work in the community, it is easier for us to take it a step further. And it is easier for us that once we stabilize the patient, like the APML patient, she's gone back to her gynecologist for the further treatment. So in that, the patient bond is also there, that, the doctor was seeing her in the earlier has done everything, and she sent me because the blood products were not available in the place and for other reason, than to think that, okay, she missed something, she would have evaluated it different, and then that. So I personally feel whatever references we get, other than the transplant, of course, is the cases where the workup has been so extensive that we just have to contribute it to a bit further and take up from there, leading to save the life of the patient. Thank you. Any questions? I'm free to answer. Thank you. Sure, sir.
I think it's important for you to help us to think outside the box.
Sure, sir.
Inside the box, we will think.
Yes.
As a physician, that's what's important for us.
Yes, sir.
So, we have, I can think of many things. Hello. Hello. Yeah, so, I had a child who I referred with, who had, it turned out to be a case of CML, and a child from a poor background who needed 7 lakhs of rupees for her treatment. Fortunately, I sent her to St. John's, the college which I come from, and we were able to raise 4 lakhs of rupees for her. So there's one story in the, some years back. And I have a gentleman who I want to refer to Dr. Vidya actually, and Dr. Joshi, and she's here. And hello, we've not met face to face, but we've spoken a lot to each other for various indications. And this patient again was there, who's coming to me, who has a PO of almost 15 days. And we have nothing I can get on it. Everything I've worked up, take the works, I've tried. Nothing, it's just nothing coming up at all. Hemoglobin has come down from about 12 to 11.3. And we have quite high CRP, starting from about 45, it's come still sitting around 40. After clinical examination, there's nothing. There's no liver, there's no spleen, there's no node, nothing. He has some tinea corporis out here, nothing else. And there's absolutely nothing that we have to tell us any clue what's happening. I would have sent it to Dr. but she was busy, and I actually referred the patient to Manipal. And this is, on the case that we see, it's a little different here. It's in this whole realm, doctor, where we move into all this, things that we can't do in the clinic, like a PTCT, for example. You go with APTT and you do PTT and you do things like that. You try and get clues from the liver function test or something else, but tells you there's something going wrong. So it tells us if a patient has hemoglobin just coming down a bit and nothing else, the fever going on, evening rise of temperature, this is consistently, 101 temperature, consistently documented, not something like that. And you know what's happening. You've checked all the normal things that we check for evening rise of temperature. So would you do a bone marrow on this patient?
So I am always of the opinion that bone marrow is a tool for diagnosis, and whenever I counsel the patient, I always tell them you can wait for days and days and keep guessing one by one what treatment can happen, or I can just do the bone marrow where the factory where all cells are made, and I can tell you in a day or two what's happening. And if they are okay with it, I immediately tell them, look, pain is something that can be tolerated, but losing somebody is absolutely not going to be tolerated. So
have you evolved any less painful methods?
Sir, there is a less painful method, definitely, but the finance of that less painful is general anesthesia where we can do it. Some patients electively ask for bone marrow in anesthesia settings. So we have done it. But having said that, with you all being around, with our anesthetist friends being around, we can just do it on bedside. It's not going to be that painful. And the pain usually lasts till the procedure is over and they just get up and leave. It's many times, so we don't do stern because, and it has nothing that they'll get up and they will leave once they know the diagnosis. I have one patient whom I just transplanted, a young guy of 28 years. He came from Mysore. He told strictly, don't touch me. They partied on me in Mysore. 1 hour, 2 hours, they did bone marrow. They said not enough material, send him out, this and that. I told him, look, let me do it. I guarantee you, as much as pain, you give me that pain later. I'm equally with you. He allowed, now he plays Punjabi songs when I'm doing his marrow. Attenders complain, look, sir, I like, look, please, let him have his moment of this. So just the convincing. If you feel that bone marrow needs to be done to tell the story early, I would just suggest that please suggest the bone marrow, because I have seen patients, they invariably put this word, oh, we were not informed about bone marrow. because now I know my friends are trying to come down on his pain and other factors, and they are like, okay. And his statement to everything, he will not tell I said pain, this, that. He'll put a word saying, no, nobody told me about bone marrow. So there, yeah.
Just one last one.
Yeah.
There was a case I discussed with Dr. Joshi and someone close to me, and she had leukocytoclastic vasculitis and presented with the full thing, which looked like purpura to start with. And we were a bit of dealing, but as we started working up the patient, we knew that we're dealing with autoimmune disease. Again, there. So again, just if I wish I had cases and the pictures to show my colleagues here and show you how it can very so closely resemble purpura. And you think it's purpura when it's just an LCD, which is totally different. And you're worried about that small percentage of patients who will go into kidney complications. Thank you.
Okay. Thank you. Yes.
I've been seeing in the past 1.5 years, nearly 4 patients of multiple.
Yes.
And the reference layer is normal.
Yes.
And we did
Yes. Yes.
But then we went on to investigate further.
Yes.
Close up, mic close up. Close up, close up.
So 3 of these people have turned out to be acute myeloblastic leukemias. And here the platelet count is normal, the count is also within the range. So, and they are not smokers. So first, these sort of cases are increasing.
Yes, I completely agree with you. With AML, patient had just come to us that he was going to Sweden for a trip and his company is taking him to Sweden. He sent his reports to 1mg for a workup, and lo and behold, they have sent back saying that you have AML. And the patient is just sitting there and asking us, why I have no problem.
They are doing very well with the management, because before any change in the sphere, they started them on treatment.
Yes, yes.
So there was regression, and they are on follow-up.
Yes. Yes.
Just can I add one word, Doctor?
Yes.
So when Dr. Singh is absolutely right, because I had my uncle of mine who's 19 years old, my father's youngest brother. He was in Mangalore way back in the early 70s, and he had fever, and usually the diagnosis is typhoid. You give one antibiotic, a second, third antibiotic is not getting better, then you try the normal thing. You're in Mangalore, you take treat for malaria, etc., etc. He landed up in Bombay, he was diagnosed with acute myeloid leukemia. My father got all the drugs that he could get from abroad in those days. He didn't survive very long. That was the end of the story. I have a sister, a religious sister, who's under my care. And this is an 80-year-old lady who has got COPD and actually ACOS also, which is various other complications like osteoporosis and lumbar fracture. When we were doing her routine investigations, we came across WBC counts of about 17,000 with about 50% of neutrophils. Doctor, I leave it to you from here to explain and tell us what we should be looking when we see such pictures.
So first, when I see WBC count as 17,000, then my first thing is to look at the platelets. Now, in 80 years and above 60, generally, if you have a low-grade pancytopenia or the bicytopenia with one of them being high, still I do a early bone marrow because the MDS group is hiding somewhere beneath these findings. So that's what is my first. Yeah, so that's what I would take up further. Yes, thank you.
Thank you, Dr. Nishit. Now we have our next speaker, Dr. Madhusudhan.N, Consultant, Department of Radiation Oncology, Fortis Hospital, Banargata Road. The topic for the discussion is role of radiation therapy in cancer management.
Hello and good evening, everyone. I am Dr. Madhusudhan, Senior Consultant Radiation Oncologist at Fortis Hospital. I would like to thank my colleagues Thianeshwaran and Nishit for the wonderful presentation. So, there are 3 main treatments for cancer or tumors when we go. It is surgery, radiation therapy, and then the systemic therapy. Systemic therapy includes chemotherapy, immunotherapy, targeted therapy. Today, I'm here to just brief about radiation therapy or radiation oncology. So if someone asks me what is radiation, it's something very difficult to tell the definition of radiation. It's because radiation is, in one word, is an invisible word. That's the reason it is difficult. But you can only see the effects and side effects of radiation therapy. So if you go to the pure, impure, what is radiation? The radiation is a form of energy which travels in air, emitted either by nucleus or a non-stable electron. That is the pure definition of radiations. There are so many types of radiation which is present around the world in the atmosphere actually. If you say even the microwave, there is some radiation. Go ultraviolet light, there is some radiation. Around us, radiation will be there. But what makes this radiation different from the other types of radiations, what we see? The radiation, what we use, the therapeutically, has the capacity to make a nucleus unstable or make or damage the DNA, especially double-stranded DNA. The radiation, what we use, should have the capacity to damage the DNA and cause the cell killings. The radiation was discovered back in 1895 by Mr. Röntgen. Then there is something called radioactivity. There are two things. In the today's modern world, so there is something called linear accelerators, there is something called radioactivity naturally occurring or we use with the help of nuclear reactors. The linear accelerators, we use the external beam radiation machine is, we generate the X-rays or radiation therapy. Whereas when we use the brachytherapy, we use the radioactive material. The difference between the linear accelerator and radioactive material is that the radioactive material keep on constantly producing the radiation therapy. You must have seen previously about even 20 years ago, we used to use the cobalt radiations. Cobalt, even nowadays brachytherapy, they constantly producing the radiation therapy, whether the machine is switch on or switch off actually. But only we will be having a protective guard around this one. Whereas with the modern day linear accelerator, you switch on, the radiation will be on. You switch off, it will be off. It's a matter of seconds or microseconds. This is the first patient, retinoblastoma, treated with linear accelerator in 1957. And the first cobalt machine in Italy was installed in 1953. And today in the modern day world, we are slowly out of this the old-fashioned cobalt machines. Most of the centers in India, we are facing out these cobalt machines. We are coming with the state-of-the-art linear accelerator, as I told, which is switch on, switch off. So these are the different types of radiation therapy, what we use in the oncology. There's something called alpha rays, there is something called beta rays, gamma rays, X-rays, and neutrons. Even beyond these, protons, then carbanions. So the use of this high-end treatment is basically, we are going towards precision treatment. Reduce the side effects and give only the effects what is required. Today's world, it is not only just you treat the cancer, you treat the cancer with good quality of life. What matters is it's not the cure. There was a days you treat the cancer, you cure it. But today, because most of them are patients who do come or educated patients, just don't come with a cure. We want to add life to the years. Quality of life, what is important. And there is where the precision medicine is there. The precision medicine is there in surgery, precision medicine is there in radiation oncology, it is there in the chemotherapy. So where can we use this radiation? We can use as a upfront therapy, we can use along with surgery, we can use along with chemotherapy, we can use after the radiation therapy. There are different ways how we use radiation therapy. So this is the prototype machines, what we have at our hospital in Fortis. One is the linear accelerators on the left side. That is a hybrid machine which is capable of doing the conventional treatment and also capable of doing a stereotactic, very high-end treatments also. Where the other one on the right side is a brachytherapy machines. Nowadays we commonly use the brachytherapy only for the gynecological malignancies. Previously we used to use for the esophageal cancers too, and then the recurrent tongue cancers. So as I told you, there are different types of radiation therapy. So one is basically, as I told you, it's a precision oncology. We should not, what we are to treat, we should know. What we are not supposed to treat, we should know. That is called the modern radiation therapy, nothing but conformal radiation therapy. There are different ways of conformal radiation therapy like IMRT, IGRT, VMAT. Go with the recent techniques, what we go, have more precision and less toxicities. This is just an example of a radiation to the brain. About like 20 years ago, if there is a one tumor in the brain, we used to treat the whole brain. But later came, about 10 years ago, then it came the IMRT actually. What we used to do is, we used to treat only the tumor, but with less specificity. Today, you are seeing that whatever is visible, we only treat that with a millimeter and a sub-millimeter accuracy. This is called the precision medicine. The technology we are using for this latest treatments. This is just an example of what we are doing at our centers. There are two lesions in the brain. Just to show how the distribution makes, if we use the IMRT 10 years ago treatment, today with the stereotactic treatment, you can see that low dose region is comparatively significantly reduced with the use of this stereotactic radiation therapy. What is the use of this stereotactic therapy is to reduce the toxicity and give good quality of life. We all of us know whole brain radiation therapy can cause cognitive defects. With the use of this stereotactic treatment, we can reduce those cognitive side effects, or we can make it almost nil. Yesterday, I had come across a patient with 8 or 9 lesions in the brain, a case of lung cancer with 8 or 9 lesions, with a very good performance status. What we consider before treating is not just you treat the patient. What is the performance status of the patient? How well the other regions are being controlled outside the thing. So if you gone to some other hospital outside, they must have treated the whole brain. I did not do the whole brain. I picked each and every lesions I treated. This is called the berry picking and doing the treatment. This is what the stereotactic therapy or the high-end treatment comes into place. And as I told, like this, we have gone beyond the CT scans, we have gone beyond the MRI. Just an example of, if you look at this photo, if somebody says what is the tumor here, if you look at the T2 images on the extreme left, it's quite a large. Say for example, there is 20 centimeter volume. So you give the contrast, then actual volume of the tumor reduces from 20 to 10. And when you do the PET, brain specific PET scan you do, still the volume reduces to maybe 2 cc or 5 cc. So what we have to do is, we have to use the modern technologies to reduce the toxic to the brain. So there is a transition from conventional treatment to stereotactic treatment. Conventional treatment, say for example, a prostate cancer, we know that prostate cancer can be treated either with a surgery or with a radiation therapy. These are the 2 treatment modalities which can cure the prostate cancer when it is still localized. About 5-10 years ago, we used to treat prostate cancer for 8 weeks. Maybe still in some parts of India, they still treat the prostate cancer, local therapy with the 8 weeks of treatment. But today, I can treat even just in 1 day also. That's a curative dose, what I can give, 1 to 5 days of treatment. That is called stereotactic treatment. Not only in prostate, so many benign tumors. Radiation oncology is not just restricted to the malignant diseases. We treat a multiple number of non-malignant diseases. In a month, about 30 to 40% of what the cases, neurosurgery cases I treat include the benign tumors like pituitary adenomas, meningiomas, AV malformations. And it is not suppose like colon cancer goes to the liver. Even with 3 or 5 lesions, we can treat with stereotactic surgery. We work as a team, combining medical oncology, radiation oncology, surgical oncology. Whatever the surgeon can remove, we'll leave it to the surgeon. What he cannot remove, which is not accessible to the surgeon, we do with the stereotactic treatment. I told you in examples like stage 1, stage 2 lung cancer. Today, the results are as good as doing a pneumonectomy or lobectomy in stage 1 and stage 2 cancers. Localized prostate cancer, hepatocellular cancers with portal vein invasion, localized, then unresectable pancreatic cancers, limited lung, liver, and brain lesions, and non-malignant diseases, which I already told, schwannomas, AV malformations, glomus tumors. So a large number of ENT glomus tumors I see. At least in 1 or 2 in a month I will get from the ENT surgeons. So with this, I want to give examples of the cases which I have done. Recently have treated a case of 32-year-old gentleman, a recurrent brain tumor, pilocytic astrocytoma. In around 2019, I think he was operated. It was a left temporal lobe tumor, grade 1 tumor. The neurosurgeon completely resected it. Generally, grade 1 tumor does not recur. And unfortunately, this young gentleman recurred within 1.5 years. So the neurosurgeon referred to me, and I took it as a challenge because it was very difficult to convince the patient. He had problems of first of all, he was psychologically down, and he had problems of gait, it was problems of vision, all these things he had. It was a hard time for me to convince him to take the treatment. And today it's almost like 1.5, 2 years now. He's completely normal. He's able to go to his work. He's playing cricket. This is one example of where radiation therapy still works in low-grade tumors. Generally, we give radiation therapy to the high-grade tumor or grade 2 in specific conditions. So this is one more example I told you about. A CA colon presented with visual symptoms. Okay. On the left side, what you see is a lesion on the down. On the same image, after done 3 months, there is a complete disappearance of the lesion. AVM, I told you, I do also treat many non-malignant conditions, AV malformations, which we know the standard of treatment for the AV malformation is microdissection or embolizations. There are people who doesn't want the surgery is where eloquent areas in the brain. Surgery will be difficult, or because of the age, or some people say embolization doesn't want to undergo. In these cases, we can do the radiosurgery. Just one fraction, you hardly take 30 minutes of time, you can finish it. Completely a non-invasive treatment. Another case of brain metastasis, which I treated. And one more lady, a CA colon, presented with difficulty in walking. When we did a CT scan and PET scan, we found that there was a spinal lesions which was compressing at the L1, L2 level, compressing on the exiting nerve roots. And you can see on the right side is the pre-treatment image, left side is the post-treatment image, with a complete disappear, almost complete disappearance on the CT scan. This is also PET CT image of one more spinal mets patient. Hepatocellular carcinoma. Many of you must have come across hepatocellular carcinoma. We know that hepatocellular carcinoma can be sometimes multifocal. This is one classic example of a multifocal hepatocellular carcinoma. He was around like 80 years of age with AFP increasing, and even the creatinine was also 2 because of CKD. The challenges we had in this case are CKD, old age, and multifocal tumor. We had the discussed with the hepatobiliary surgeon. We discussed as a team with medical oncology, radiation oncology, hepatobiliary surgeon. The hepatobiliary surgeon said that he can only remove the one. The rest of the thing should be taken care by the systemic therapy. So I explained the patients. I did a stereotactic radiotherapy to all the 3 or 4 lesions, which was visible. And we started something called immunotherapy. Today, the modern world is something called like use the multiple treatment to give good quality of life and control the tumor. And it's almost more than 2 years today. He's still fine. I told you the prostate CA rectum case. CA lower rectum case. Many of the surgeons know that rectal case, especially the lower rectal malignancies, we have to go for a permanent colostomy. a lady from Goa. She had come from Goa. She clearly said in the beginning that she will not go for this permanent colostomy. So what we did was this. We did neoadjuvant chemotherapy and radiation therapy, and immediately after surgery, immediately after the radiation therapy, I did a PET scan. There was a complete disappearance of the tumor. And these are the cases where you can opt. About 1/3 to 1/4 of the cases can still be saved of permanent colostomy. Prostate cancer, I told you, this is just treated with 3 fractions of treatment with very good response. Trigeminal neuralgia. So most of you heard of trigeminal neuralgia. One of the disease with excruciating pain which anybody can experience actually. So what we can do, other than the micro dissection, there is something called a radiosurgical rhizotomy. That means you do a stereotactic radiosurgery exactly at the way it arises out of the pons. You pick it at 2 to 3 millimeters and give a very extremely high dose of radiation with the highest accuracy of millimeters of wave accuracy. And you can see excellent responses. I have treated about 8 to 10 cases with trigeminal neuralgia. Like this pituitary adenoma, pituitary adenomas, meningiomas, schwannomas, neurofibromas, bilateral neurofibromas, NF2 with bilateral acoustic schwannomas. Lot of cases for the to date. Okay. Thalamic AV malformations. So as I told, today's world, it's all about precision oncology. Use whatever is available. Give the patient the best quality of life. At the same time, curing or controlling the disease. Nobody wants to live for 100 years with bad quality. Even if somebody wants to live with 3 years, that should be with a good quality of life. Okay. Final tribute to the Mary Curie and Marie Curie. So they are the one who discovered and used radiation to the maximum extent. Both Curie's experimental radiation burns, both accidentally and voluntarily, were exposed to extensive dose of radiations while conducting the research. They experienced radiation sickness, and Marie Curie died of aplastic anemia in 1934. Even now, all their papers from 1990s, even our cookbooks, are too dangerous to touch because we know that the radioactivity of the radium is 1,500 years. And their laboratory books are kept in special lead boxes, and people who want to see them have to wear a lead protective clothing. So this is the machine what we have at Electron, Fortis Cancer Institute. Okay, this is a hybrid machine which is capable of whatever the cases which I have shown, all were done with this machine. So, thank you everyone.
Does anybody else have any questions? Because I have 3 questions. Yeah. Dr. One is, you talked about various things that you're using radiotherapy also for. One is, what about things like the hydrated cysts or, some sort of things in the liver or the lungs, etc., which are let's say, benign or...
No, sir. We do not use the radiation or radiosurgery for the hydrated cysts.
It's benign
one
condition.
thing is, when there are easily accessible other modality of treatment is available, we do not use. Because when you use a radiation therapy, there is some, especially for the non-malignant diseases, the patient should be aware that there is some unknown or some very rare thing called second malignancies, especially the sarcomas. In the brain, we use very commonly this. I must have done about, say for example, 150 cases of meningiomas, more than 500 cases of pituitary adenomas. Only non-malignant I must have treated more than 500. It is because that brain, there is no other alternatives on it. There are with the other areas of the treatment. Where it is possible, like we use the other modalities where it is possible. We go for the radiation as a last resort. And another thing is, especially when there is a cystic lesions are there, radiation therapy is not so useful in a cystic lesion. It is good in a solid lesions.
But the second question, I had an interesting discussion. These are just my own thoughts. We always talked about, some of the medical people always laugh at the surgeons, and the surgeons always laugh at the medical people. When I got out of medical school in the early end of the 7th decade, 1970s, when I got medical school, if you had something between your ears, you did cardiology or neurology or whatever it was. And then came the internet revolution, and if you were just very mediocre, you became a surgeon. And then came the internet revolution. With the click of a mouse, you had all the information you had. And then it became important that if you can do something, you were something. So then surgery became safe, anesthesia became safe, and all the great surgeons, pulled out half the lung out in 3 minutes or something of that sort, were no longer great because you're looking at that, minimal invasive surgery, and everybody started getting to the surgery bucket, The cardiothoracic surgeon was less important when you started doing for PTCs, etc., etc. And we're talking about how important, medical oncologists and radiation oncologists and surgical oncologists are. I think one day we'll come to a stage when, when you're doing so much invasive radiology also, that you'll be going right to the tumor and giving the medicine there or the radiation there or doing the surgery there itself with embolization. There will be no difference between these three disciplines. This is just my thought.
Yes,
So,
definitely. Because there will be, so what we, as I told you, it's all about precision treatment. It's all about precision treatment. Recently, I treated one more lady, a young lady, now in case of osteosarcoma of the leg, who got amputated her leg with one metastasis just sticking to the lung. It's about 3 centimeters. Okay. So she has received multiple lines of chemotherapy. So I explained the risk that radiation therapy, when it is attached to the heart, actually, when it attached to the heart, it's quite difficult. It's not an easy thing because heart moves, the lung moves, the patient moves during the treatment. I already told them that my treatment is a millimeter accuracy treatment. It's a lot of challenges will be there. And that too, she's a young lady. She must be around 25, 26 only. So I took a lot of risk and I treated that case. Today, it's almost complete, near complete response to the tumor. And I given really very marginally less dose what I give with protecting the heart also.
Regarding AV malformation treatment with radiation,
Yes, sir.
was the other modalities, was it considered like intervention radiology, embolization or anything like that?
Yes,
Or,
yes. Generally, before it comes to the radiation oncologist, most of the times it will be come through the neurosurgeon only. Neurosurgeons are the one who refer the cases for the radiosurgery. And before that, the DSA must have been done. They must have consulted the interventional radiologist. They must have already discussed. And either patient is not willing for DSA or DSA must have been difficult, or in the eloquent areas, patient doesn't want to undergo for a radiosurgery, or patients with a 70, 75 with a comorbidities like diabetes, hypertension, doesn't want to go under the risk of surgeries. And most of the cases who comes to the radiation oncology, we are at the receiving end and we are at the low end. Even if you take a stage 1, stage 2 lung cancer, if it's a prostate cancers, these are the neglected cases we take. These are the challenging cases what we take. Because even if it goes to the urologist, they take the good cases actually. They do the surgeries. And what comes to us end of the day is those cases who reject it, surgery either because of medical, surgical or personal reasons.
what complications likely to arise with radiation?
The major complications with the radiation, especially to the brain, is the radiation necrosis. It happens is one out of 2 cases, radiation necrosis, wherein there is an exaggerated response of the brain tissue to the radiation therapy, where there is something called pseudo tumor. There will be a progression in the tumor. You feel that patient will be all right from the first scan. After 6 months, you will see there is a profound increase. Something comes with a raised intracranial tension like headache, vomiting. And we do an MRI, will come to know. Looks like a pseudo progression, we will say. And you give steroids, they respond most of the cases.
That one last question.
Yes.
You talked about movement, or the heart or the lungs moving.
Yes.
But again, in the abdomen also, when you're doing radiation, there is movement. The diaphragm is
Yes,
moving.
yes.
Things like this is definitely moving. Now, in the old days when we were seeing patients being treated, especially for pelvic problems and things like that, we had a lot of radiation cystitis or radiation proctitis, which is horrible for the patient.
Yes.
That continuously, it's worse like having an acute urinary infection and it's never going to get better.
Yes.
Or you have that tenesmus that you have this acute large
Yes.
bowel diarrhea and you feel like going. And I've seen people who've got colonic cancer, who have that, and they have had their surgery, radiotherapy, whatever it is. And this is a very horrible part of the treatment. Now, is there something that radiotherapy can give you which is better than surgery or something else, which is I don't know, or is it the other way around?
The radiation cystitis and radiation proctitis are the known complications to the pelvic region, especially following the carcinoma of the cervix, where the dose in the carcinoma of the cervix, which compared to the CA rectum, if you give for a CA rectum or a CA anal canal, the dose is quite less. Okay. Whereas for the CA cervix, we give almost go to the dose like 90 gray. And especially it used to be common with the olden days radiation therapy, I told cobalt radiation therapy, where you cannot have the control over where you are going to give radiation. With the today's modern day, each day I'm going to see what dose of radiation, not only the tumor gets, even the normal tissue like the surrounding normal tissue, rectum and bladder, how much is getting. Within seconds I can come to know. If I feel that at this moment the radiation is taking more rectal dose or more, I can stop the radiation, I can call the patient the very next day also. That's what today's modern day radiation.
Hello. A very simple question. How do you acquire this pinpoint accuracy without damaging the neighboring tissues?
So we have a system called ABC, especially for moving organs at our hospital, active breath control systems. Each hospital and each machine is having a different set of techniques to control these movements actually. At our hospital, we have something called ABC, wherein we train the patients. We freeze the patient's breath movement. I cannot freeze the heart movements, but I can only freeze the breathing movements. Say, for example, I train the patient for a couple of days, 2 to 3 days. I analyze the patient breath, how the patient is taking the breath. And I will give the training so that take a deep breath and freeze the movement. And when the patient is taking the breath and freezing the movement, there will be a remote control button will be given to the patients. During that time only the treatment will be on. If the patient release, suppose patient wants to take a breath, release the button, automatically the machine stops.
Thank you.
One last question.
Yes, sir.
Excellent presentation, Dr. Madhusudhan. We really enjoyed your presentation today. This is regarding surgeries in the head and neck region, maxillofacial region, basically. Many a time we'll have to resect the jaw, maybe hemimandibulectomy or hemimaxillectomies, and we are forced to do a reconstruction using mini plates.
Yes.
Most of them use titanium mini plates.
Yes.
Will that interfere with radiation? How is it? We had a problem. We used to have issues in the past. How is it now? What are your thoughts on it? Can we?
So very good questions. It's fantastic questions. Generally, the radiation therapy when we give in the post-op setting is slightly lesser than what we give in a radical setting. Radical setting in the sense like radiation is the only curative statement. Suppose, for example, a laryngeal case comes where the organ preservation is important. We give a dose called 70 gray dose of radiation. Whereas in the post-operative setting, most of the time we restrict the dose to the 60 gray or 62 gray, 63 gray. So in their way, we are trying to reduce the toxicity to the patient, and of course we are trying to spare the graft also at the same time. Another question is what you are placing a titanium one. Yes, there will be a little but a negligible increased scattering of the radiation to the surrounding parts with the titanium or whatever the metal. Even the bone itself is also there will be metal, but that's not a significant problem for the day-to-day treatment. Theoretically, yes, but when it comes to the clinic, when we practice, that won't going to be a matter for us.
So after surgery and placing these implants, what is the time lag you would suggest before you start your radiotherapy?
Ideally, between 4 to 6 weeks post-surgery is the time where we have to start the adjuvant treatment, whether it's a chemotherapy or radiation therapy. Because by the end of 3 or 4 weeks, patient would have also healed, the wound would have healed, patient would have started to take the nutrition properly. We wound also completely healed. The time when the patient start eating, when the wound is completely healed, that's the time when we take it. It's an arbitrary to 4 to 6 weeks. Even we can start as early as end of the 3 weeks only. But generally, at least 3 weeks we wait.
So there will not be any issue of pathological fractures where the plates are being placed after radiation?
No, generally no, sir, generally. Because the radiation tolerance of the bones is quite high. It has to go beyond 70 gray. What we use in adjuvant setting is 60 gray or 66 gray. 70 gray very rarely go because radical cases of the head and neck cancer, we go up to 70. But I have never seen a case of fracture because of radiation therapy in any case of radiation.
Thank you so much.
Thank you, sir.
Thank you, sir. All our speakers will be available for questions during the dinner session. Due to the constraint of time, we'll move on to our next session. May I please invite Dr. Sarat Chandra Pingali, Consultant, Department of Surgical Oncology, Fortis Hospital, Banargata Road, to talk about the role of surgery in oncology.
A very good evening, senior doctors, delegates, and dear friends. So I will give, already we are running late, I think. So I will try to cover, I will give you an overview of surgical oncology. That is the role of surgery in cancer, diagnosis and management. I will try to make the presentation as interesting and as brief as possible. Myself, Dr. Sarat Chandra. So for somebody to practice surgical oncology should have a good knowledge of not only the surgery, the techniques of surgery, but also of oncology. One should know when to operate, when not to operate also. So when the patient comes to us in the OPD, we evaluate, we do his proper complete history taking, physical examination, and we try to arrive at a diagnosis. Whenever the word cancer is uttered, all of us should be reminded of three very important things. Number one is diagnosis. Number two is staging, and number three is treatment. So usually diagnosis first, staging next, and treatment is the third aspect. But not necessarily everything flows in this particular sequence. Sometimes we do surgery and it is only after surgery that we get to know the actual stage of the disease. But nevertheless, these are the three most important words that all of us should remember: diagnosis, staging, and treatment. So also we assess the surgical fitness and we have to counsel the patient. So I will try to go through the slides quickly and not miss important aspects of surgical oncology. So this is very important. What is cancer? All of us know, it's been already discussed. Why the problem? Because the problem with, there's no problem with tuberculosis, there's no problem with Hansen's disease, there's no problem with most of the other diseases, but cancer is a problem because it doesn't present in early stage. Most of the cancers concerned with the internal organs of our body, they present at a stage where already they have gone beyond the purview of possible cure. Because internal organ cancers don't present in early stage. By the time they produce some symptoms, it's already gone beyond the stage of control. This is the unfortunate thing about cancer. So the solution is to pick up cancer early. So how to pick up cancer early? So it's entirely a different topic. Any persistent symptom, this is very important. So whenever we go for cancer talks and all, they will ask 7 cardinal signs of cancer, 10 cardinal signs of cancer. According to me, if you ask me, a person who takes coffee every day, doesn't take one day, he will get headache. Person with a brain tumor also can get headache. So how do we differentiate both? It is very difficult actually clinically to differentiate both. So what I suggest everyone is, after being treated by a primary physician for about 1 week or 2 weeks, if the symptoms don't regress after taking the basic treatment, or even if they regress with the basic medication, they are going to come back after stopping medicines, then we should go a little deep and think whether we are missing something underlying. So somebody has diarrhea, we take ciprofloxacin for a week, it subsides. Again after 2 weeks we get diarrhea, again ciprofloxacin, again diarrhea, again ciprofloxacin. No, it is not like that. So if symptoms are recurring after stopping basic medication, or if they are not responding to the basic medication given by the primary physician, definitely we should go deeper and think whether anything underlying we are missing or not. So this is how even one of very close people to us had got diagnosed with colon cancer. So this is very important. After basic treatment, if the symptoms don't respond, or even if they respond after stopping medicine, within no time they're coming back again and again, we are having to use the same medication, then this is the time we need to go and consult a specialist. So how cancer spreads, all these things I'm not going to cover because time shortage. So there are various theories how cancer spread. Halstead said it spreads in a stepwise manner, meaning breast cancer for stage 1 in the breast, stage 2 in the axilla, and stage 3 to the systemic organs. Fisher is the one who said cancer is a systemic disease to start with. So that means he said once some patient has breast cancer, already cells are there, cancer cells are there in circulation, cancer cells are there already there in bone marrow. He said cancer is a systemic disease to start with. So whenever 2 people are fighting, the third person will come into picture. He is Hellman. He said in some cases Halstead is correct, in some other cases Fisher is correct. So as on today, the understanding of cancer spread is according to the Hellman's hypothesis. So these are the three most important words with respect to cancer all of us should know. So the staging of cancer is clinical and pathological staging. So this is very important. Even for a patient who is going to die in half an hour, treatment will be there. There is no time when there is no treatment. In cancer, apart from tuberculosis or Hansen's disease or any other infectious disease, we also look at the intent of treatment in cancer. What is the intention of giving treatment? Whether it's possible cure or it's only to control the symptoms. This is very important. Now, our understanding of science is very incomplete. We see many ladies who have never smoked, they develop lung cancer. Why should they develop lung cancer? Smokers don't develop lung cancer sometimes. So our understanding of science as on today is very incomplete. And is there a guarantee for this disease? No, unfortunately. And can it be predicted? Yes, it can be better predicted now than 20 years than what it was 20 years earlier because of the molecular diagnostics. So everything, there are many questions, no answers. This is a patient with basal cell carcinoma of the temporal region. So why a basal cell carcinoma doesn't have lymph node spread? Why it doesn't spread to other organs in the body? There is no answer as on today. And some cancers, this is a recurrent cancer with soft tissue sarcoma with chest wall metastasis. Some cancers spread very fast. So cancer treatment is a multidisciplinary treatment already covered by my earlier colleagues. So this is the most important slide. So surgery has a big role in treatment of and diagnosis and treatment of cancer. It can be done as a preventive modality in certain genetic conditions, like where we know that there are certain cancers. Suppose cancers may run in families. If we know that there is a known genetic mutation, then there are preventive surgeries that can be offered. We know breast preventive mastectomies are done in BRCA mutation patients. So cancer has a big role in diagnosis of cancers, like we do punch biopsies, true cut biopsies, different types of excision biopsies. So cancer has a big role in diagnosis of cancers. And for most of the solid organ cancers, which are limited to the local area or the local regional area, meaning the lymph nodal basin, cancer is offered as a potentially curative treatment with curative intent. So sometimes we do surgeries for cancer patients in an emergency setting, like laryngeal cancer. Patient comes in stridor, we have to do emergency tracheostomy. Patient comes with intestinal obstruction, we have to do an emergency colostomy or an ileostomy. And sometimes we offer surgery as a palliative treatment. Patient has a bleeding tumor, he's losing blood. So then we have to do some form of an amputation. So there are various palliative settings. Suppose inoperable gastric cancer on laparotomy, we do a palliative gastrojejunostomy with the intention that at least as long as the patient lives, he should be able to eat. So various palliative surgeries are there. And sometimes post-chemo radiation, if there is a residual tumor, like a residual tonsillar carcinoma, post-chemo radiation, we offer surgery, if possible, as a salvage. Salvage means we're trying to save the patient in spite of patient having a persistent disease post-chemo radiation. So in recurrent setting also, cancer has a role in certain scenarios. This is the list of genetic disorders in which preventive surgeries are done. Preventive orchidectomy, preventive colectomy, preventive thyroidectomy, preventive mastectomy in known genetic disorders, which are known to run in families. So these are the various procedures. Sometimes after removing the mass, we will get the diagnosis. Suppose, for example, patient comes with an ovarian cyst, tumor markers are normal. Unless we remove the ovary, we are not knowing whether it is a benign tumor or a malignant tumor. Similarly, with the case of renal masses, somebody comes with a renal mass, isolated, limited to the kidney, there is no extra-renal disease anywhere else. So all the imaging findings are in favor of a renal cell carcinoma. It is only after removing the kidney that we get a proper diagnosis. Similarly, lymph nodal masses, diagnosis of lymphoma, we remove the lymph nodes. Some pancreatic masses also, we don't do biopsies. We do a distal pancreatectomy or rarely Whipple's procedure. Only after the procedure we will get the diagnosis. So those three words, what I told, diagnosis, staging and treatment. Sometimes after the treatment we get the diagnosis. So that can also happen. So everything that looks like cancer, we should not think that it's cancer. When I saw this patient for the first time, I thought these are secondaries in the neck. But ultimately, after evaluation and treatment, it turned out to be a carotid body tumor. So with this, we need to keep in mind, everything that looks like cancer is not a cancer. This patient, she's a lady who came with A CT scan suggests you of solid ovarian mass. They were very afraid that it's going to be a cancer. But when we did a laparotomy, finally it turned out to be nothing but a broad ligament fibroid, which is totally a benign disease. This patient, I thought 100% she had cancer because ulcerated mass over the breast. So it's bleeding. I thought it's cancer. I did biopsy. It came as a spindle cell neoplasm. I thought pathologist not giving correct report. I sent to another pathologist. Even he said it's a benign spindle cell neoplasm. Then actually we could not apply for a Arogyasri scheme. So she got it done under payment mode because cancer report is not there. Biopsy reported cancer is not there. Then finally I operated. It came as myofibroblastic disease, tumor of the breast, very rare entity. This is only to say that everything that looks like cancer is not cancer. I know one patient who attempted suicide when the ENT surgeon told her that this is possibly cancer. So we should never disclose to the patient that you are likely having a cancer unless we have a biopsy report. Now what if the patient dies with suicide and the disease is benign? We definitely feel very bad. So cancer, unless the pathology report comes, it is not confirmed. So we should be careful about it. So cancer has a big role in staging of cancers. We stage cancers by doing laparoscopy, thoracoscopy, and staging laparotomy is the surgery what we do for ovarian confined tumors. So this is ovarian tumor. There is no extra ovarian disease. There is no ascites, no lymph nodes, no amental deposits. Tumor markers are normal. So then we do a laparotomy and we have to remove the ovary in toto and then send it to the lab intact without rupturing the capsule as much as possible. Then we get the diagnosis, whether it's benign or a malignant or a borderline ovarian tumor. Laparoscopy should not be done for all ovarian tumors. The laparoscopy in ovarian cysts has a role when you have a high clinical suspicion of endometriosis or of a PCOD. Rest all cases, it is open surgery is much better because you are not supposed to remove the tumor piecemeal. You will cause spillage of the tumor, and which will upstage the disease from a stage 1A to 1C. From a situation where patient doesn't need adjuvant chemotherapy, she will land in a situation where you are forced to give chemotherapy. So laparoscopy in ovarian cyst has to be applied very selectively with proper clinical judgment. And frozen section is very important for such tumors. Many times we see patients who come with post removal of uterus, post removal of ovarian cyst, with a diagnosis of cancer. So frozen section is very handy and compulsory for all ovarian cysts. If it is malignant in the same sitting, we can do a pelvic lymphadenectomy or omentectomy by involving the oncosurgeon or a specialist who can do the procedure and without the patient having to undergo a second procedure later on. So surgery is done in cancer patients for most of the solid tumors in curable stage. So initially when surgery, Halstead designed surgery for cancer breast, it was a big surgery. He removed the muscles of the chest wall, everything he removed. So later on, when they found a beneficial effect for the big surgeries, they tried doing even bigger surgeries. Because big surgery gave good result, they thought, let us clear the supraclavicular fossa also and see whether it gives even better results. But then with simultaneous advancements in chemotherapy and radiation therapies, the extent of surgery, not the role of surgery, the extent of surgery started shrinking. Now it is less surgery and lesser surgery. Most of the times, nowadays we are doing organ preservation surgeries, so which is the common practice nowadays. But one thing has to be remembered by all of us, there is no replacement for a properly done surgery. Somebody does incomplete surgery, we should not think let us compensate by giving chemotherapy or by radiotherapy. It is never. So a proper surgery is very important for a proper outcome. So emergency situations, airway obstruction, intestinal obstruction, and not only these, sometimes we operate, we land in post-operative complications for which we have to take the patient back to OT again. Like for example, this patient many years back, I did a transthoracic esophagectomy. Post-chemo radiation, squamous cell carcinoma of middle third of esophagus, transthoracic esophagectomy done. On the third and fourth post-operative day, patient started pouring 3 to 4 liters of clear fluid in the intercostal drainage tubes. So it is a leak from the chyle duct, thoracic duct. It is there between the azygous vein and the aorta. So we had to re-explore this patient. We reopened the chest because we didn't have laparoscopy facility in that hospital where I did. So we had to re-explore the chest. If lap is there, then we can do it laparoscopically. So you can see multiple clips that are applied between the azygous vein and the aorta area. Blindly we apply multiple clips so that the chyle leak is controlled. What happens if chyle leak is not controlled? Patient loses albumin overnight. Overnight patient developed anasarca. So she's immediately going to malnutrition, lot of fluid loss, she's not going to survive. So fortunately by God's grace, patient survived and she was discharged okay. So not every complication is major. Sometimes we have minor complications. Like for example, I did laryngectomy. There is a small, this is the tracheostomy hole you can see in small pharyngocutaneous fistula. Such things can be managed conservatively. So we do surgery with palliative intention also. What is the meaning of palliation? Palliation is the prevention or treatment of symptoms or complications of a disease. This is the WHO definition of palliation. So, and sometimes, see, this is the patient who had soft tissue sarcoma of the left shoulder region. Morning you do the dressing, by afternoon pads are soaked with blood. Again by evening pads are soaked with blood. So we're losing a lot of blood. We did a 4-quarter amputation in this patient. After that patient went home happy. So definitely surgery plays a big role in such tumors. So many palliative amputations we do. Suppose osteosarcoma with lung metastasis, patient is distressing pain. Whatever painkiller you are giving, he is not able to sleep. So you do an amputation, he is relieved of the pain. So these are palliative surgeries. Salvage surgeries, I told you, these are the surgeries done when there is a persistent tumor or a recurrent tumor after non-surgical treatments are given. So these are the recurrences needing cancer surgery. This particular boy, he came to me with a recurrent soft tissue sarcoma of the elbow region. So 5 minutes. So recurrent soft tissue sarcoma of the elbow region. So MRI was showing that it is abutting the major neurovascular bundle of the upper limb. This is the upper limb. So I told him intraoperatively I will see if there is if I can lift the adventitia of the brachial vessels and get a margin intraoperatively, I will preserve your limb. Otherwise I will take an intraop decision to amputate above elbow. Then he has given consent for both. So that day we operated from morning 9 o'clock till night 8 o'clock. So ultimately we could get a margin. You can see the nerves hanging there, ulnar nerve on the right side, ulnar nerve and the median nerve. And then we did a latissimus dorsi myocutaneous flap and tunneled it through the axilla to fill in the defect. And this was almost 6-7 years after the procedure is done and patient is still alive. I mean, I have his phone number also. He is married and now almost it's been 10 years after the surgery. So if I worked in Hyderabad, he came to Hyderabad for follow-up. When he came to Bangalore, he came to Bangalore for follow-up. So recurrent tumors, sometimes with proper surgery, God favors, patient may be cured. This is the patient with the residual nodal disease, post-chemoradiation, CA tonsil. We did radical neck dissection. So while staging cancers, we use a lot of imaging modalities. Nowadays, different types of scans are there. But what our Professor Vijay Kumar in Kidwai, he has told that is whenever we are ordering scans, we should think of 3 things. One is 3 A's, applicability, availability, and affordability. So we cannot have the best scans in all places. We cannot have affordable patients in all scenarios. So all these 3 things we should consider and take a proper decision and judgment. Not only the tumor being operable, the patient also should have operable general condition. That's what we call performance status. So nutritional status, pulmonary function, comorbidities, all of them have an impact on the outcome. For example, this patient, we operated long back in Bangalore, esophageal cancer. She needed transthoracic esophagectomy. She's a post recently undergone CABG surgery. In fact, to be honest, I was also afraid to operate on her. We tried to scare the patient so that she'll not give the consent. But in spite of doing everything, they gave consent for surgery. Fortunately, nothing happened to the patient and she recovered. So it's not only the patient and surgeon, but the equipment, the backup, the supportive specialties, the anesthesia team, the post-operative nursing. So everything should be good for a good surgical outcome. You can see this operating table, it breaks in between. This is the position we give for a right adrenalectomy. So operability means there are 2 words in surgical oncology, resectability and operability. Operability means whether it's metastatic or non-metastatic. Resectable means it may be metastatic, but still tumor is resectable. So sometimes we take an intraoperative decision whether to
For all abdominal cancer surgeries, there will be a 5% chance of inoperability. Rely heavily on frozen section. For example, this patient with gastric cancer has peritoneal nodules after opening. So this patient, we took consent soft tissue sarcoma for wide excision versus amputation. Both consents we have taken because totally involving the sciatic nerve, we had to go for an amputation. Nowadays, with recent advances, they are doing nerve grafting, vascular grafting, PTFE grafts they are placing. So even with advanced limb cancers, they are trying to preserve the limb. Not only the surgery, post-operative care should be good. This patient presented nasal cancer. I did medial maxillectomy. Such patients need good post-operative care. And pathology is the pillar of oncology. Without pathology, none of us would be able to do anything. These are all the things which we need, the frozen section, cytogenetics, IHC, everything is important. And intraoperative frozen section is important. Grossing is important. Gross pathology and microscopic pathology, both are important. This is the mandibulectomy specimen, subtotal mandibulectomy. Proper grossing has to be done. Cut margins have to be properly assessed. The lymph nodes have to be dissected out. So all this is a specimen, or I will quickly show the surgical specimens. It's the APR specimen. You can see the shiny mesorectal fascia. This is the Wertheim's specimen for CA cervix. You can see the parametrium, which is stretched with the forceps and not just a simple hysterectomy. And we need support from other specialties also. This patient was operated in Jaideva Hospital. So patient had a left renal tumor with a cavo-atrial thrombus. He was put on CABG machine. We took the help of cardiac surgeon, and nephrectomy with cavo-atrial thrombectomy was done by atriotomy, and the white shiny tumor you can see inside. With all these, quality of life, sometimes patients will have loss of function. They can't talk. They have disfigured face. They have a motion bag on the abdomen, urine bag on the abdomen. They're dependent on tube feeds, and it's a burden to the family. But even with all these things, the surgeon should not decide that if I do this surgery, patient will not have good quality of life. It is the patient who decides that whether to undergo surgery or not. So there is a gap theory with respect to quality of life in oncology. Gap means the difference between the expectations and the reality. If I have very high expectations, in spite of best result, I will be totally depressed. If I have very low expectations, I should live and spend my life with family members, I should eat, somehow I should be with my family. Then if the patient is cured, they will be very happy. So this patient, whenever he walked after the medial maxillectomy, whenever we look at his face, we used to get depressed because it used to look like a leprosy face. But patient always used to come smiling into the OPD. Doctor is unhappy, but patient is happy. So why I am showing this picture is patient is the person who is going to decide about the quality of life, whether to undergo surgery or not, and not the doctor. So laryngectomy, this is esophagectomy, which leaked, and we did a subcutaneous pre-sternal bypass. This is a total colectomy specimen, radical cystectomy with ileal conduit. This patient underwent total glossectomy and a PM pectoralis major myocutaneous flap and is tube feed dependent. So we need support from all specialties. Patient counseling is very important, which actually, it gives an idea to him what to expect after the treatment is done. So surgical access, cut margins, boundaries of dissection, signs of inoperability. This is the most important side in surgical oncology. Number one priority is for oncological clearance. Number two is for function preservation. And number three is cosmesis. For the sake of looking good or for the sake of preserving the function, we should not compromise on the oncological clearance because that will affect the life of the patient. So this is a post-commando resection. Before we did pectoralis major myocutaneous flap, you can see hemimandibulectomy and modified radical neck dissection. So the PMMC flapping, this axis, sometimes axis is very important. You can see the pancreatic body neck tumor. We had to take a T abdominal incision to do a distal pancreatectomy and splenectomy. So this is the specimen. So this is transthoracic esophagectomy. You can see the esophagus being mobilized, and this is the esophagus specimen. So the right adrenal tumor. This is the post-gastrectomy D2 lymph node dissection. You can see the ligated left gastric vessels, common hepatic artery and the splenic artery. This is a gallbladder cancer. We did hemicolectomy with radical cholecystectomy and wedge resection of the liver. This is a posterior pelvic exentration with uterus and the rectum removed. This patient is a software engineer. In spite of being educated, and somebody said it's a benign breast tumor, she just kept it observing and got fixed to the chest wall. So post-neoadjuvant chemotherapy, we did a mastectomy with the segmental chest wall resection and mesh placement. She is also, I think it is 6-7 years after her treatment, she got married, she delivered 2 kids. She's presently in Chennai. So this is a abdominoperineal resection from the perineal aspect. You can see the prostate, bladder base, and the seminal vesicles. So sometimes when we open, we find inoperable findings. You can see gastric cancer with omental deposit. So anatomy, one should have good knowledge of the anatomy and the variations. You can see the facial nerve, 5 branches after doing a superficial parotidectomy, and even the deep lobe is removed. You can see all the 5 branches. Conservative total parotidectomy done. Conservative means conserving all branches of the facial nerve. So sometimes vascular anomalies will be there. This is a Whipple's procedure, aberrant right hepatic artery. So nowadays minimal invasive surgery is very much in vogue, and you can see hardly make out that surgery is done. This is my first patient of Vardem cystectomy done laparoscopically. After a few years, hardly anything is seen. Scars are not seen. This is a left nephrectomy laparoscopic. Nowadays robotic surgery is being done. We are doing very much in Fortis Hospital. So the lab advantages of lap surgery are quicker recovery, less pain, early mobilization, early return to work. Added to this, robotic surgery will also offer the advantages of 3D visualization for the surgeon, and pelvic surgeries, especially nerve sparing surgeries, and surgeon can operate comfortably by sitting. So reconstruction, rehabilitation is very important. Multiple flaps, we need the support of plastic subtotal mandibulectomy. So lower lip cancer, this was done by my professor Vijay Kumar. So there's a stage procedure. So the prosthesis for oronasal separation post surgery for hard palate. So shoulder physiotherapy following oral surgery, laryngectomy by PMMC flap post laryngectomy. And nowadays organ preservation is the it's the thing in practice. Limb salvage surgery for bone tumors is being practiced. So outcomes are very important in surgical oncology. The patient with left renal cell carcinoma with a lot of retroperitoneal nodes, solitary liver metastasis. So we did left nephrectomy, retroperitoneal lymph node dissection, and liver metastatectomy. So with all this, I will conclude my talk. Thank you very much for giving me this opportunity. Thank you all. Thank you for this hospital. So any doubts are there, we can discuss. Sir, please.
2 quick questions, Doctor. One is, do you remove any precancerous lesions like erythroplasia of Querat? And second thing is, tell us about how you figure out operative margins.
Sorry, sir. First question, erythroplasia.
Like any precancerous lesions, do you remove them in any, or just observe them? The second thing is, observing may not be feasible if patients are not educated and will not come
Sir, we will know that it is erythroplasia only after removing it, sir.
Yeah. So
because suppose on the glans penis patient has a lesion,
yeah,
unless we biopsy it, we will not know whether it's pre-malignant or malignant. And if we have done a